let's kick off. We have an interesting hour ahead. I'm Roopen Arya from King's, and thank you all for joining us for today's special Thrombosis UK World Thrombosis Day edition. So let's talk clots. So we have three fantastic speakers who will focus on different aspects of VTE risk assessment. Each speaker will speak for 15 minutes and we'll reserve the questions for a 15-minute block at the end. So it's a great pleasure to introduce the first speaker, Dr. Lara Roberts, who is a consultant hematologist at King's in London, where she is the clinical lead for venous thromboembolism and a very active researcher in the world of VTE prevention and treatment. So we are now 10 years on from the launch of the National VTE Prevention Program in England, when risk assessment of all hospitalized patients was made mandatory. So Lara will bring us up to date with the results of the GIRFT thrombosis survey. Over to you, Lara.
Thank you. Just to confirm, you can see my slides, Roopen? Yeah. Thank you, and thank you to Thrombosis UK for providing a platform for us to share these initial findings from the first GIRFT thrombosis survey. And for those unfamiliar, GIRFT stands for Getting It Right First Time, and it's a national quality improvement programme in England aimed at identifying and reducing unwanted variation in clinical practice. So as I'm sure most people joining will be aware, venous thromboembolism comprising deep vein thrombosis and pulmonary embolism is common, with an incidence in adults of 1 in 1,000, and the risk increases with age, such that in the elderly it approaches 1%. More than half of all events are associated with hospitalisation or surgery, and the incidence in hospital is being reported as much higher, approaching 2%. We know that appropriate thromboprophylaxis given to patients at high risk of VTE reduces this risk by up to 60%. And in recognition of that, prevention of VTE was declared a top clinical priority for improving patient safety in England and other parts of the world over a decade ago. And as Roopen mentioned, the National VTE Prevention Programme in England was launched in 2010. It was a systematic approach which was underpinned by the introduction of mandatory documented VTE risk assessment of all adult patients on admission to hospital. There was mandatory central reporting of risk assessment rates and a financial penalty for failing to achieve a 90% risk assessment rate. And this was underpinned by national comprehensive VTE prevention guidance issued by NICE, along with a quality standard defining best practice and a recommendation to perform patient-level root cause analysis of all hospital-associated thrombosis. And the aims of this ambitious programme were to reduce avoidable death, disability and ill health associated with VTE and hospitalisation, and to embed VTE prevention into routine NHS care. And the VTE risk assessment remains in the standard NHS contract today. And this shows VTE risk assessment rates. So central reporting started in July 2010. The percentage of risk assessment is on the right, and you can see that we achieved the 90% risk assessment rate nationally in late 2011, and that was subsequently sustained. The target was increased to 95% in year 3, and that was again achieved and is still met today at just over 95%. But at the end of last year, 28% of NHS hospitals failed to achieve this target. So that was one driver to us looking further at VTE prevention practice. But the only other outcome measure available nationally in the UK is this outcome that's published by the NHS Outcomes Framework, and NHS Digital, and reports post-discharge VTE deaths within 90 days. And again, over the last decade, there's been a 20% reduction in VTE deaths. But we don't have any other metrics regarding implementation or provision of thromboprophylaxis or the impact on hospital-associated VTE nationally. So the GIRFT thrombosis survey had a broad range of aims, and I'm not going to be able to discuss the findings following all of these today, but the ones highlighted in blue I will address, and this includes variation in organisational approach to VTE prevention, the provision of appropriate anticoagulant thromboprophylaxis, provision of patient information about VTE risk, rates of hospital-associated thrombosis over the survey period, and the proportion of events deemed potentially preventable. So the survey launched a year ago, and the intention at launch was to collect data for 6 months. It comprised 3 surveys, a single organisational survey looking at VTE prevention resource and practice, a prospective survey of VTE prevention practice collecting patient-level data, and a prospective survey of hospital-associated thrombosis events, again collecting patient-level data. And as everyone will be aware, the COVID pandemic in England hit really in March, and we anticipated that was going to cause problems for people contributing to the survey, and ultimately decided to extend the survey to allow data collection up till the end of May, hoping that we'd also capture some COVID-related VTE events, and allowing people to continue to submit their data up till the end of August, so that where people have been redeployed, they might be able to catch up on returning to usual duties. So I'm only going to report findings from NHS hospitals in England. There are also private providers that participated along with hospitals in Wales. But of NHS hospitals, there are 144 trusts invited, 103 survey participants, which include 96 unique trusts, with 7 additional sites aligned with one of those trusts. So it's just over 2/3 participating. So we can't consider the findings to be representative of the whole of the NHS. And we asked participants whether they had a VTE prevention role in post, and just over 2/3 of those taking part did. We asked whether they routinely identify hospital-associated thrombosis, and the majority did. And we asked whether they use the National VTE Risk Assessment tool for VTE risk assessment, and again, the majority did. And importantly, of the 11 who didn't, the majority of these reported using a locally modified version of the national tool, which suggests that there is still a systemic approach across all participants to identifying patients at risk. The VTE prevention survey invited hospitals to contribute 4 cases of each subtype of admission of patients who had been identified as being at high VTE risk each month. So we're anticipating receiving 120 submissions per participant. And in total, we received 9,282 submissions. There were 98 participants, and the mean number of submissions was 76, so it did fall short of what we'd aimed. And this is partly attributed to COVID. We saw a 25% drop off in the number of cases submitted in March. And when we look at the use of anticoagulant prophylaxis, so this is just in patients who are not at risk of bleeding, so who should be considered for anticoagulant prophylaxis, we can see that generally prescription is fairly high, so overall 88% of patients were prescribed anticoagulant thromboprophylaxis. There is a little bit of variation between regions, but there is quite broad variation between individual sites. This ranged from 40% up to 100%. But we were also interested in whether the prophylaxis was actually delivered, and we asked whether there were any missed doses that were either due to the patient refusing the prophylaxis or where there wasn't a clinically documented reason for omission. And again, you can see this varied across regions from just under 5% to over 12%. But again, across individual sites, there was wide variation, with some sites reporting no patients with any missed doses, up to 55% of patients with missed doses. And we also wanted to know about delivery of patient information. This is a quality standard within the NICE guidance. So patients should all receive verbal and written information about their VTE risk on admission and discharge from hospital. We just asked about whether written information was received at the time of data collection. But overall, this was fairly low. So it's 30% of patients overall received written information, again, with some variation across the region. And wide variation between sites, so ranging from 0 up to 100%. And moving on to the final survey, which was looking at patient level data regarding the hospital-associated thrombosis. And there was a drop-off in response here, so only 70 sites participated, so less than half of all NHS trusts invited. There were 3,877 individual episodes of HAT included, and there was wide variation in the number reported per site, so a median of 43, but a range of 1 to 277. And again, it's likely COVID impacted on contributing to this survey. We saw 30% less cases submitted from March compared to earlier in the survey period. And we used hospital episode statistics to identify admissions. Unfortunately, the data is not available for the same time period as the survey, so we've had to extrapolate the data from the previous year. And that likely means that we're underestimating slightly, particularly with the advent of COVID. But the average rate was 2.3 per 1,000 admissions. And if we removed low reporters, where they may have been either unable to contribute all of their data or identify all HAT, the number of centres providing more than 50 cases drops to half, but the rate is then 3.4 per 1,000 admissions. And just to illustrate that there is again wide variation between sites. So the highest rate was 7.3 per 1,000 admissions. But centres reporting only 1 or 2 cases had a much lower rate of 0.3, and I suspect this is due to incomplete reporting. So again, if we remove low reporting centres, we see the range varies from 1.8 to 7.3 per 1,000 admissions. And we then went on, we'd asked participants to consider whether the event was potentially preventable or not. And again, there's wide variation between individual sites from 0 to 100%, but also interregional variation up to almost 20%. But again, if we remove the low reporting centres, that variation reduces, but is still broad, so from 0% up to 48% at individual sites, and still with variation between centres. The ones with no potentially preventing events still tended to be lower reporters, so it's possible that there are events not contributed to the survey. And so the limitations of the survey is that the participation was entirely voluntary, and we're unable to mandate participation or put pressure on people to continue to participate during COVID. And the quality of the data is entirely dependent on that entered. So we haven't modified data based on our own evaluation. I think COVID did have a clear impact in that we saw a significant reduction in the number of cases submitted from March. And that's likely due to the people involved being redeployed or additional clinical duties. And the HAT survey is limited by us being reliant on hospitals identifying all episodes of HAT. And I think some hospitals probably didn't identify all episodes or weren't able to contribute all of their data. So I think those HAT rates need to be interpreted cautiously. but it is still a first insight into real-world VTE prevention practice nationally in England. And it does highlight that there is significant variation in VTE prevention practice. Whilst there were high rates of appropriate prescription of anticoagulant prophylaxis, there are also higher than anticipated proportion of patients with missed doses. There's a clear need that we need to improve provision of patient information, particularly as HAT can occur post-discharge, and if patients are unaware of the symptoms and the importance of re-presenting should they develop, that could have serious consequences. And there's wide variation in rates of HAT, with a significant proportion still deemed potentially preventable. So there's still some work to do. So we're in the process of preparing individual site packs for distribution. So if you did take part in the survey, you should shortly be receiving details of how to access the individual site packs for you to review locally and develop an action plan, depending on where there are areas that need to be addressed. And we're asking that those plans are fed back centrally to GIRFT. And there's a national report in production, which will also be shared when available. And I'd just like to acknowledge my co-clinical leads, Professor Arya and Professor Hunt, Anne-Marie Ridgton, who is a project manager at GIRFT, Brian Ward at Business Reform, who developed the online surveys, and Marco Di Caro and Christian Roy at Edge Health, who have been involved in the analysis of the data. Thank you.
Thanks, Lara. There's a lot of important information, and this is was a big challenge to address these issues at a national level to try and help us improve patient care. There's lots of questions, but I'll save them for later. Next, it's a great pleasure to introduce Dr. Marc Blondon, who's a clinician and researcher working in angiology and hemostasis unit of the Geneva University Hospitals. Having trained as a hospital internist, he trained in epidemiology and clinical research with projects on cardiovascular disease and venous thromboembolism. His particular interests lie in women's health and the prevention of hospital-related thrombosis. So Marc is going to address risk assessment in pregnancy and postpartum. Over to you, Marc.
Thank you very much, Roopen. Can you confirm that my slides are viewable? Perfect. So hello, everyone. So thank you for this very neat invitation. I'm quite honored to be talking about this topic, especially in front of a UK audience. So we'll be taking the next 15 minutes discussing the role of risk assessment in pregnancy and postpartum. I really focus on postpartum. And this is kind of a hard topic with wide variations, again, similarly to what Lara has just highlighted for medical thromboprophylaxis. I'm not going to go in details about the burden of VTE in pregnancy, but just say that it remains the second most common direct cause of maternal mortality in the UK and likely in Europe and North America as well. And the reason for this burden of disease throughout pregnancy is related really to the triad of Virchow. We know that there's a hypercoagulability state that will develop gradually throughout pregnancy and spike in the postpartum period, and that's underlined here by this prospective study showing increasing levels of D-dimer throughout the antenatal period. Flow velocity is also important, and I believe this is an old Scottish study showing that in the femoral vein and the popliteal vein, the flows will actually decrease in terms of their speed throughout the antenatal period, and we only come back to the normal speeds at the end of the postpartum period. And the third important item is obviously delivery itself, which induces a lot of trauma, whether it's related to a simple vaginal delivery or C-section. And so when we look at these population-based data, which come from England, the work of Sultan and colleagues, Sultan who's done a lot of amazing work in the field in the past 5 and 10 years, we know that in the antenatal period, the incident rates of VTE will increase compared to a non-pregnant state. But really the low-hanging fruit for risk stratification is in the postpartum period. This is where the incidence rate is the highest. That's where more than half of the cases will occur. And if we want to have a period with naturally the most efficient short-term drug, we should focus really on this postpartum period. And that's what we'll be talking about mostly here. When we think about risk stratification, Lara has just talked about this, but there are multiple risk score. You are using the UK model, but there are other risk score that exist, the IMPROVE, the Padua. I'm gonna obviously highlight the Geneva score also. And these combine a couple of classical risk factors. Some of them will apply to obstetrical settings and some of them won't. Obviously, a personal history of VTE will apply, known thrombophilia will apply, but there are very few women with active cancer or cardiac failure or obviously in old age or recent cardiovascular disease. So we have to think a bit out of the box for obstetrical risk stratification. Another setting where risk stratification is different is for hip replacement therapy and for knee replacement therapy, and Banne will likely discuss this, where until recently, at least, it was pretty much a thromboprophylaxis for all with no risk stratification. But these two situations have something that's very different from obstetrical risk stratification. It's the actual rate of major VTE. When we look at the placebo arm of the big the phase 3 randomized trials of medical thromboprophylaxis, and we look at major VTE, including asymptomatic proximal VTE, but not distal DVT, the risk of VTE over 90 days is usually around 3 to 4%. Hip and knee replacement, same definition, it's close to 5%. But when we look at the antepartum and the postpartum periods, we have much lower risks, so 0.1 and 0.2%. So we're trying to prevent something that's really rare, although in the population of healthy women, it represents a very important condition. Graphically, if you take these thousands women, that would be the risk of VTE if these were medical inpatients. And that's the risk for postpartum VTE. So again, think about how we want to risk stratify this whole population to prevent just those two events. Let's take a look at what happened in the past 20 years. So above the line is the medical thromboprophylaxis history. We've spent first the energy on documenting the efficacy of thromboprophylaxis. You have here the Kaplan-Meier curve, the Medinox study, and there's been 4 major thromboprophylaxis trials. And then in the past 10 years, what we've done is trying to implement our knowledge, develop scores in order to give our patients the best care. And we even are at the stage where we're actually reassessing the efficacy through some trials that are ongoing, such as the symptoms trial. We've done things really differently in terms of risk assessment and thromboprophylaxis for pregnancy. We've spent, I'm sorry, I think my slides, there we go. Slides were not working. So we've spent really a lot of energy in the past 20 to 30 years trying to look at specific risk factor for risk stratification in the obstetrical setting. And again, a lot of the really good work comes from England and the UK. And we've found associations with a lot of different risk factors, which we'll come back to. We don't have an RCT to demonstrate the efficacy of heparin in that setting. We have a pseudo RCT with a non-sequential, non-randomized allocation of either 2 different low molecular weight heparin or a no treatment arm, which suggests a very good efficacy of low molecular weight heparin to reduce postpartum VTE, but it's almost a too good to be true study. And what has been done in the past 8 years is multiple guidelines trying to suggest what the best options for our patients would be, especially in the postpartum period, and the development of one score. So there are really 2 ways to risk stratify. The first one is to do a combination of risk factors and then say above that threshold of number of severity of risk factors, one should get the kind of a thromboprophylaxis, either short-term or long-term. This is the ARCOG guidelines. You are likely very well aware of these guidelines, which you likely use in clinical practice. We identify high-risk women, mainly those who've had a previous VTE, low-risk women who don't have risk factors, only a few minor risk factors. And then there's this really hard and challenging intermediate risk with some intermediate risk factor, C-section in labor, strong obesity, or a combination of minor risk factors. So this is quite complex, but it's very guidant. So it clearly shows what women should receive. On the contrary, you have the American College of Obstetrician and Gynecologists guidance document. That says nothing much. It just says that if there's no history of VTE and no thrombophilia in the postpartum, well, care providers can pretty much do what they want. They can just simply check the patient or give thromboprophylaxis if there are multiple risk factors, but without giving a clear guidance. So quite a bit of difference and variation here. The other approach would be to use an actual risk threshold, and we have this risk score that estimates an individual risk of VTE within the next 6 weeks after delivery. That was done by Sultan et al. Again, using British and Swedish data, and we'll come back to this. So what we've done with a medical student this year is develop a cohort of 300 women who delivered at the Geneva University Hospital and just apply theoretically what the guidelines would have said. And so if we look at the ARCOG on our sample, 4 out of 10 women would have received thromboprophylaxis. That's 1 out of 4 for vaginal delivery and 9 out of 10 for cesarean sections. That's very different from what the American would actually do. They would only give it to less than 10% of the sample, mainly in cesarean sections, because there's really no guidance for vaginal delivery. What we've done, and I think that's the novelty here, is use the score that was developed to actually assess what the actual risk would be in those women deemed at high risk. So if we look at the 40% of women who were supposed to get some thromboprophylaxis based on the ARCOG guidelines, their mean risk is only 0.12%, meaning that we would actually have to give the thromboprophylaxis to close to 1,200 women in order to prevent 1 VTE event. The numbers are not quite higher, not that higher for the ACOG and ACCP, just a bit, with NNTs that remain quite high. We don't have a good sense of what the sensitivity of these 2 rules are. We have one estimate of sensitivity for the ARCOG. The sensitivity is the proportion of women who would end up having a DVT or P that are deemed at high risk, and that's only 63%. So again, graphically, if we look at these 1,000 women, the ARCOG would suggest to give thromboprophylaxis, mostly short-term, to 40%, and only pretty much 1 out of 2 women who would develop DVT would have received the drug. So I'm not saying this is not the right way, I'm just saying we have to actually acknowledge what we're doing using guidelines. If we were to use the approach of an absolute risk, this is a more scientific approach, although there might be some biases which I'll not go into today. But the big question is, what threshold of risk is sufficient to justify thromboprophylaxis? And we really have no good data. We had done a decision analysis model 15 years ago suggesting there was already some marginal benefit when women had a risk greater than 0.2%. Experts, or people that say they're experts and that belong in, for instance, in the ASH guidelines, said that it was between 1 and 3%, so that's quite high. And when we ask women in the antepartum thromboprophylaxis setting, if the risk is 2.5%, only 60% will actually say, well, that's high enough for me to take thromboprophylaxis in the antepartum period. that risk might be actually lower to be acceptable in the postpartum, given that it's much shorter, but we don't have any data. So what's clear today? I think what's clear is the high risk. We know that if a woman has had a previous VTE and is not given thromboprophylaxis in the postpartum, then her risk of having a recurrence in the 6 weeks after delivery is 8%. And that's a combined number from 2 cohort studies published about 15 to 20 years ago. And that's high enough to clearly justify thromboprophylaxis for 6 weeks, in my view. Thrombophilia and family history, I think that's also clear that the risk is above 1%, and whether it's strong or minor thrombophilia, it really doesn't matter. And we have also data showing that homozygous factor V Leiden and prothrombin mutation or compound heterozygote state between those 2 mutations carries a high postpartum VTE risk independently of family history. What's also clear is that women without risk factor have really a low risk and should not receive thromboprophylaxis, at least pharmacological thromboprophylaxis. What's less clear is pretty much the rest. What do we do with a woman who only has an emergency C-section, who has some hallmark of placental insufficiency that can be a low birth weight, premature delivery? What about stillbirth, infection, major bleeding? These are all non-minor risk factors. I would call them intermediate risk factor, but likely they do not make the actual absolute risk great enough to really justify thromboprophylaxis in most women. So risk stratification for postpartum delivery is difficult. There's still a lot of unanswered questions, mostly because we don't know what the effectiveness and safety of thromboprophylaxis is. We know that our current schemes have subpar sensitivity. I've shown you the 63% from the RGOG rule. If we were to use a risk score, there are some doubts about validity. It would be good to have another external validation of that risk model. What we are not sure of is the combination of risk factors. What's an acceptable VTE risk threshold to justify thromboprophylaxis? What is its cost effectiveness? And let's not forget that there's quite a bit of perinatal VTE events that will occur actually before the first injection of postpartum thromboprophylaxis, and obviously we're not able to prevent those events. So there's a lot to do. What we've done in the past 20 years is really highlight the burden of pregnancy-related VTE, highlight individual risk factors, and highlight who a very low risk and very high risk woman is. What we need to understand is the combination of risk factors, obviously the effectiveness and safety of thromboprophylaxis, and something that has to be done is to elicit the views and preference of postpartum women with regards to thromboprophylaxis. I'm not aware of any data in that field. So risk stratification for pregnancy and the postpartum VTE, it's very important. We're actually asking that question every 10 seconds in Europe. There are 5 million births every year. We're good at understanding individual risk factors. We're less good at actually predicting actual risks. I've shown you that guidelines differ dramatically, and obviously the number needed to treat also differs dramatically. We should not wait for the knowledge before actually implementing what is best, but when we do implement what we think is best, we should assess it and make sure that it goes in the right direction. And I will also highlight that we need a pragmatic RCT in that field to make sure that the safety and effectiveness is as expected. Thank you very much.
Thanks, Marc, for an excellent talk, and I think a truly unique perspective about this subject. So we will take up questions on this later. So the third speaker is Dr. Banne Nemeth from Leiden University Medical Center, where he is an orthopedic surgery resident. He recently received his PhD cum laude for his thesis entitled Venous Thrombosis following lower leg cast immobilization and knee arthroscopy. And he has pioneered an individualized approach to risk assessment in orthopedics. And I'll give a plug here for his forum paper in the latest issue of the Journal of Thrombosis Hemostasis. So his research is on complications following orthopedic surgery, and in particular, prevention of venous thromboembolism. Over to you, Banne.
Thank you very much, Roopen. My name is Banne Nemeth, and I'm a resident orthopedic surgery in Leiden, and also a clinical epidemiologist. And I will talk on risk assessment in orthopedics. Thank you very much for the invitation. And what I want to discuss today with you is whether prediction is actually the future in orthopedics as well. Moment, these are my conflicts of interest. So in orthopedics, we tend to individualize the type of implants according to patient-specific characteristics. So this might look all as similar implants to you, but I can assure you they are not. These have different coatings, different sizes, cruciate retaining, total knees, etc. But strangely enough, as we individualize the type of implant, we do not individualize the type of prophylaxis in orthopedic surgery. Most guidelines just state we have to provide any form of pharmacological thromboprophylaxis for 10 to 14 or 28 days of one of the following pharmacological products. And we do not really differentiate between the type of product according to patient characteristics. So what I want to discuss to you today with you is that the incidence of thrombosis is declining following total hip and knee arthroplasty. I will focus on that today. And that due to this decline, a lot of low-risk patients actually need less prophylaxis, whereas high-risk patients need intensified regimens of prophylaxis. And in order to do so, risk stratification is really essential to reduce both VTE, but also bleeding complications. What we've seen in the last decades is an enormous decline in the incidence of venous thrombosis following these type of procedures. And this is mainly because of the introduction of anticoagulants throughout the recent years. But what I want to emphasize is that not only these products, but also post-surgical patient care, as well as new surgical approaches, has led to this enormous decline in the incidence. It's even been estimated that if we do not give any form of thromboprophylaxis, pharmacological prophylaxis following total hip and knee arthroplasty, the risk is only 3.5%. And this was nicely shown already, I think, in 1991. This was a very small randomized controlled trial published in The Lancet from a Danish group, in which they randomized 78 patients scheduled for total hip arthroplasty. And the only difference was patients were admitted post-surgically to department A or B. And in department A, patients were mobilized on the 4th day, whereas in department B, they were mobilized on the 9th day. During the first 5 months of the study, and after 5 months, they decided to mobilize these patients in department B on the 4th day as well. So totally different as we do nowadays, but still a huge difference in post-operative care. And what the authors noticed was an enormous difference in the occurrence of asymptomatic clots in this study. You can see a tremendous decrease in the amount of clots when patients were mobilized faster after surgery. So this indicates that mobility and post-surgical care has contributed a lot to this decline in the incidence of VTE. Nowadays, the estimates are around 1.5%. So 1.5% of patients still develop VTE despite all our efforts, different types of anticoagulants and different types of post-surgical strategies. And the question is, how can this be explained if we give that much thromboprophylaxis to all of our patients? So first of all, I think thromboprophylaxis is not 100% effective. It's obvious, but we need to think of that. This is an example we've published 2 years ago in a different group. These were patients undergoing knee arthroscopy surgery, so very minor surgery. These were randomized between low molecular weight heparin and no anticoagulation. And what you see is that 0.7% in the low molecular weight heparin group and 0.4% in the group without anticoagulation developed a VTE. So it's no effectiveness in this patient group whatsoever. And a similar finding was shown in another podcast trial, which included patients with lower leg cast immobilization. So I won't get into details on the study, but what I want to show with this slide is there's not 100% effectiveness of this anticoagulation. So then we have to ask ourselves, how can we further reduce this number if thromboprophylaxis on a population level is not 100% effective? And by doing so, we always have to aim for the optimal balance between preventing a VTE at the expense of increased risk of major bleeding, of course. And what we have to keep in mind is that orthopedic surgery is not an extremely high risk population anymore. We have now a lot of patients who actually have a very low risk, which might even be below 1%. And those are patients included in fast-track surgery protocols, also young patients without or with very few comorbidities. And there are still those patients with a very high risk, even up to 5%, for example, with a previous thrombosis or with a genetic predisposition. And we have to think of this range of heterogeneity when we want to provide thromboprophylaxis to our patients. This is a study we performed last year. This was a cohort study in patients with a previous venous thromboembolism, and they were scheduled for orthopedic surgery. And what this study showed is that patients scheduled for major orthopedic surgery with a previous thrombosis, they have an absolute risk of VTE of 5% following 6 months. So this is an enormous risk in a high risk group. But not all orthopedic patients have this high risk anymore. And I think the best example, this is Max Verstappen. He's a very famous Formula 1 driver. He will soon, I think, win the World Championship. This is a cohort study from Denmark in 14,000 patients. And those were patients undergoing total hip and knee arthroplasty. And they were all included in a fast-track patient protocol, which means regional anesthesia, early mobilization, hospital discharge within 3 days. And what I want to emphasize is that the majority of patients, so over 95%, received only 5 days of pharmacological thromboprophylaxis. So either rivaroxaban, enoxaparin, dalteparin, or fondaparinux. And the population was very average. So the majority was 65 years or older and obese. And what the authors found is the 30-day incidence of venous thromboembolism was only 0.4%. So this is a very low incidence in a fast-track cohort. Of course, this is an underestimation. This is a short follow-up. It's a registry study, so probably the incidence is a bit higher. But still, the population average is probably around or below 1%, which is a very low risk for an orthopedic total hip and knee group with only 5 days of thromboprophylaxis. And also data from the EPCOT-2 trial, which was published 2 years ago, in which they randomized patients undergoing total hip and knee arthroplasty between a hybrid approach, so rivaroxaban and aspirin, or rivaroxaban only. The incidence was only 1% for VTE, whereas the major bleeding risk was already 0.5% in the aspirin group. So this shows that the major bleeding risk tend to increase towards the low VTE risk. And what is very important to realize is this is a study from 2008 from Marcel Levy. They looked at exclusion criteria from these large orthopedic trials. So when patients have one or more exclusion criteria, their risk of major bleeding increases tremendously. So if a patient has one exclusion criterion from one of these trials, the risk for major bleeding was 2.9 increased. So this means that we have to be very careful in giving more and more thromboprophylaxis to lower VTE rates, because major bleeding rates might increase even more. So the question then arises how to lower the risk of VTE even further. And I think the solution for that is identify high risk patients, give them more anticoagulation, and identify low risk patients, and we have to give them less anticoagulation. So ideally, we only identify this 1% or 2% of high-risk patients, there won't be any risk model able to do so. So it will be 1/3 versus 2/3 probably. And I will try to show you what individualized therapy means. This is a concept, so it's imaginary data. This is what we currently do, strategy 1. Imagine you have 1,000 patients scheduled for surgery. The baseline risk for thrombosis is 3%. When you provide thromboprophylaxis therapy to all patients with a relative risk of 0.5, the postoperative risk is 1.5. And some bleedings occur because of an increased bleeding risk. So this gives a total number of complications of 22.5. So imagine we give all of these patients an intensified regimen of thromboprophylaxis. This means, again, we have the same 1,000 patients with the same baseline risk, only now the relative risk is much lower, 0.25, because we give more thromboprophylactic therapy, which results in less venous thrombotic events, 0.75%. However, this occurs at the expense of bleeding because we give more anticoagulation, so the bleeding risk increases. So what you can see is the total number of complications stays similar, but we have less VTEs at the expense of bleedings. So is this the way forward? I doubt that. So this is an imaginary example in which we identify high-risk patients. So the baseline risk is still similar, but then stratified according to a baseline risk. So in this case, this is 1/5 of patients with a baseline risk of 12%. In this very high risk group, we can give a high dose of anticoagulants. And in this very low risk group, we can give a low dose of anticoagulants. And then if you do the similar calculations, you can see that you end up with a smaller number of complications. So this has just been published as a forum manuscript in the Journal of Thrombosis and Hemostasis. It's lots of calculations. I won't go into much details, but this is the concept of individualized therapy. So then if you want to do that, how to identify high-risk patients? So the previous speakers already discussed that a bit. This is the Caprini score. I think the score well known in surgical care. The only problem is that there is no prediction score out there which works very well in total hip or knee arthroplasty patients. This is a review which showed that 2 years ago. So the way to go forward is that we use a score that's usable in clinical practice and also can accurately predict which patients have a high risk. This is a risk score we published to identify patients with a lower, at risk for VTE with a lower leg cast immobilization. So is it perfect? Definitely not. But we aim to develop something similar for patients scheduled for total hip or knee arthroplasty. So are we there yet? No, but do the guidelines want us to be there yet? I think they are. This is an example of the European Society of Anesthesiology guidelines on VTE prevention. It's lots of text, so I made a flow chart for you. These guidelines actually say that we have to differentiate between low and high risk surgery. Well, then comes the tricky part. We have also to differentiate between low and high risk patients. And according to them, this risk, we have to give certain products. So what do the NICE guidelines tell us? Also, we have to consider or offer VTE prophylaxis in patients whose risk of VTE outweighs their risk of bleeding. So in order to do so, we need to identify VTE and bleeding risk. Currently, I think we have to do that with the best knowledge we have, discuss it with your patients, and meanwhile, we have to use all data which is out there to develop prediction models which can help us to stratify patients and prevent VTEs and bleeding complications. So I hope I have, well, not convinced, but made you enthusiastic to work on risk stratification in orthopedic surgery. And I want to thank you for your attention, especially my supervisors in Leiden and in the UK who I work with on this project. Thank you very much.
Thanks, Banne, for a very, very interesting talk and a very thoughtful perspective on a difficult area. You know, orthopedics is one of the first areas in which thromboprophylaxis was used nearly 60, 70 years ago. And yet, have we got the balance right in administering thromboprophylaxis? So there are a few questions, but I think since your talk is fresh in the mind, I will go in probably kind of reverse order. So lower limb immobilization and plaster casts. Clearly, the management in many hospitals tends to be colored by the sort of occasional adverse outcome people encounter and the coroner's request for a local SOP and to change the guidance. I mean, what is the current view on the right approach to thromboprophylaxis in that setting? What would you do?
Well, this is a subject which is up to debate, of course. I think it's what I personally do is I try to assess a patient's risk. So it's not yes or no, but I try to assess a patient's individual risk, either by a risk score or just have a conversation with the patient. What are the risk factors? Is this patient, will this patient walk? Or will this patient stay in bed all day? Just try to individualize the decision. I think the guidelines still tend to advise that it's not a yes or no question. Always try to assess VTE risk, and I think this is really the approach I like. But also to prevent unnecessary bleedings, unnecessary costs. And what's also very important is if you think you have a patient with a very high risk for VTE, you can ask yourself, is an prophylactic dose, is it that enough? Yeah. There's no evidence to dose any higher or give an intensified regimen.
There are some people who did argue at the time of the podcast studies, that you're giving a low-risk dose to a low-risk population.
Yeah.
So what do you think about that?
Definitely true, yeah.
Yeah, so I think there's many more questions, and it's going to keep you busy for years to come, I think, beginning to answer them. But I think this idea of this individualized approach is a particularly attractive one, and I'd refer people to your latest forum paper in the JTH. So then I think coming to Marc, again, it's an area in which there's such huge differences internationally, in the approach to risk assessment. And I particularly like the work that your medical student, I think Gassman, is that you had presented those kind of tables, but in the absence of RCTs or any kind of outcome data, how can we be sure of what is the right approach? Particularly, also there are no RCTs to guide the output, to show that thromboprophylaxis works and is safe.
Right. This is a really tough question because we have to implement something without actually knowing what the data are. And we have to think what is best for our patients. What surprises me most is that we haven't actually asked the patients themselves. So we don't know what the views of postpartum women are on the use of thromboprophylaxis. So if a woman is born in the UK, she has a 40% chance of getting short-term postpartum thromboprophylaxis. If she's born in the US, she probably has and if it's a vaginal delivery, she probably has a 2% chance of postpartum thromboprophylaxis. But we actually haven't asked them whether, subcutaneous injections for 10 days is reasonable, whether a risk of 1% is high enough to justify this, a risk of 0.1%. It is most likely that heparin works as well in postpartum women that it works in surgical patients. Yeah. It is likely that the safety is better in obstetrical women than surgical patients, given the lack of comorbidities and the young age. But it would be nice just to make sure that it's right. And as we've just been shown, in some settings of orthopedic, heparins do not seem to be that efficient. So how do we move forward? I think, you know, at one point, some people have to make a decision, and that can be more of a philosophical decision, political decision than a medical decision. And I do appreciate what the UK has done in terms of obstetrical thromboprophylaxis. It's been huge work. There's a lot of excellent research. It's very hard to know how to assess those outcomes. If we just look at maternal mortality, it's just the tip of the iceberg. It's going to be very hard to find signals, but there may be ways in terms of satisfaction or really just incidence rates.
Yeah, no, I think you're absolutely right. And the maternal mortality, I think, is done very robustly in the UK. And initially, there was a halving of maternal mortality, which speakers like myself had put down to our kind of thromboprophylaxis strategies. But I'm disappointed that those numbers have now leveled off. You know, that despite 46% of women receiving postpartum thromboprophylaxis. So I think there's more work to be done in that area. And I might share with you later, my colleague Jig Patel at King's has done some work on women's views on antenatal thromboprophylaxis particularly, which was published a few years ago. Yeah. But I think putting the patient at the center of it is really what it's all about, and which is why Joe from Thrombosis UK is smiling slightly. Okay, lastly, I'm aware of time. If we come to Lara and this very, very challenging and nice piece of work around hospital-associated thrombosis and VTE prevention practice. So there are 2 or 3 questions as to, you know, do we have an idea of what the right number of hats are for a hospital? Because we are conflicted between underreporting and what the Americans kind of showed in the SKIP project as definite ascertainment bias. So what is the right number of hats?
Well, the honest answer is I don't know. I don't think the actual rate of hats reflects how well a hospital performs in terms of VTE prevention. I think it is more a reflection of case finding and possibly in this case, in this survey reporting. I think there were time constraints, and I suspect that not all trusts that were taking part were able to submit all of the cases they might have done had COVID not happened. But the honest answer is I don't know what number.
Yeah. And Tamara asks that you said that 60% of VTE is hospital-associated thrombosis. Do we still believe that this is the case despite everything that is being done?
Again, from this survey, I can't comment because we only collected data on the hospital-associated events, so I don't have any figures for proportion associated with either no risk factors or cancer. I think that figure is taken from historical data from the States, and it may no longer be applicable.
Okay.
I think locally we haven't seen a reduction in our HAT rate overall because thromboprophylaxis failure is so prevalent. So I don't know whether it will have changed.
I think the really important research question is, you know, how to address that very large rump of cases of thromboprophylaxis failure. Because our current strategies are like nearly half a century old, isn't it? You know, so I think a very quick question: who will the site packs be sent to, and will private hospitals also get feedback?
Yes, so there will be site packs for the private hospitals. I can't answer who the site packs will be sent to. I have asked GIRFT this, and I understand there's a process. I have asked that the VTE leads are at least informed who it goes to, because I think they're obviously in the best position to evaluate practice and develop the action plan.
Thanks. One last question to Banne. mechanical thromboprophylaxis in orthopedic surgery? 10-second answer, yes or no. Is it
I think it's it doesn't have that much attention. We need more. I think we need much more evidence to provide that to all patients. Does it do harm? Don't think so. Although you keep patients in bed, so that's a problem. So we need more data to really answer that question.
Okay, thank you. Well, I think we've reached the end of our hour. So thank you to all the attendees. There are still some questions filtering through. We'll do our best to answer later. And I'd like to thank our really excellent faculty. I think they did a great job, and I can't think of anyone who could have done it better. Unique perspectives on our current practice. I can confirm that a recording will be available on the Thrombosis UK site within a few hours. I'd like to thank all the sponsors and supporters of Thrombosis UK and remind the attendees to visit the virtual exhibition area where stands from the various bodies and pharma companies and device companies are available. So just lastly, I'd like to thank Thrombosis UK and particularly the Chief Exec, Joe, for the absolutely fantastic job that you do throughout the year, but particularly on this day, World Thrombosis Day. Thank you all for attending. Thank you to the speakers, and hope you have a good rest of the day. Thank you.